All right, so this week we're going to talk about medications that cause psychosis. Did I do that or did you do that? All right, sorry for that. So the bottom line is a whole bunch of medications can cause psychosis, and my hope is that in this short talk, we will go over some general principles to try to help guide complex pharmacotherapy, and also go over some key medications that pose some significant risk to people with either with schizophrenia to worsen their psychosis, or that pose risk of causing de novo psychosis in people without schizophrenia. So I think I'm going to start off with 4 little pearls from my career as a consultant in complex psychopharmacology. So the first one, I cannot emphasize this enough, anybody can have any side effect from any medicine. So basically, anything can cause psychosis or worsen depression or cause apathy. I mean, human beings are astoundingly diverse, and to think that because it's not listed as a side effect, it can't be a side effect is not a great approach. So second rule is that...
Eric, sorry to interrupt. Would you go as far as to say you can have a side effect, anyone can have any side effect from any medication at any time?
So yeah, so what I broaden that to any side effect from any medication at any time, I think you mean that can a medication that's been doing well later sort of turn into do not well. And that actually does happen. So one example that comes to mind is, ironically, since I've been thinking about cannabis quite a bit lately, since I've been doing research around the cannabis psychosis connection, so I've been in this. But a classic example of a side effect emerging as a late consequence is with cannabis-induced hyperemesis. So cannabis is widely known as something to suppress nausea, and it does so fairly well, actually. But amongst some people who use it regularly, then you get this paradoxical, intractable nausea, and it comes in waves, and it's really quite horrid, which confuses people because I'm smoking the weed and it's supposed to keep the nausea down, so they're actually inadvertently now exposing themselves at higher doses to something which has turned noxious for them. Another example, other classic examples in psychiatry practice, well, people use weed a lot, so that is relevant to psychiatry practice, but other examples would be the development of tardive dyskinesia or tardive akathisia. Anything that's seen as an acute extrapyramidal side effect actually can turn up as a latent one as well. So yeah, anybody can have any side effect for medicine at any time. Yeah, we can expand it that way. So second rule, if you simply do the math, if drug 1 has 3 side effects and drug 2 has 3 side effects and drug 3 has 3 side effects, and you combine them, then you have interactions amongst them. And so literally you get an exponential increase in the number of possible interactions. And so with more drugs, you have more possibility for, shall we say, side effect mayhem. Third rule of general psychopharmacology consultation is that we know less than we imagine that we do about actual risks. We know you can read prescribing information, you can read clinical studies from the evidence-based data sets, and you can find actually really good information to guide you to think the likelihood of benefit is X%, the likelihood of side effect A is B%, and the likelihood of side effect C is Z%. So we can, with monotherapy single drugs, we can do a pretty good job. However, those efficacy and side effect data come from people who are relatively well. In other words, they have almost always moderate levels of symptoms, and they always have the ability to give informed consent. You can't do research otherwise. And moderate symptoms versus ability to provide informed consent obviously go hand in hand. So, this is a talk focused on schizophrenia care. So I'll now limit it to psychosis or to schizophrenia patients. Many, the patients that enroll in clinical studies are generally live independently. If they start off in an acute care hospital, they're going to move to independent living. A case that we're going to discuss today is somebody who's so severely ill that she's in the nursing home. All of my patients were in longer term hospitals. So many of my patients had PANSS scores way above the average PANSS score for the average clinical trial participant, and many of my patients were unable to give informed consent to be in research. So does a side effect profile for moderately ill community living Joe correspond to side effect profile for severely ill three months in hospital Sally? Probably not, I would assert. So just keep in mind that we're looking potentially at different populations of people. So what you read in the book might not translate so well into practice. Fourth rule, I alluded to it earlier. We have very good data for monotherapy. I can predict efficacy probabilities. I can predict side effect probabilities. When it comes to two drug combinations, we have a handful of studies. For example, aripiprazole combined with an antidepressant comes to mind as a combination for which we have good studies. And with that, I can predict likelihood of benefit for resolving depression, and I can predict within a ballpark the likelihood of side effects. When it comes to three drug combinations or three or more drug combinations, honestly, please let me know if you know of any data by which you can gauge efficacy or side effect risk. I'm not aware of any. And so for my typical consultation, it involves 3, 4, or 5 concurrently prescribed psychotropic medications. There's no data to guide efficacy expectations, nor to inform about the whether or not a certain side effect is likely. So general guidelines, and when then thinking about a patient with persistent symptoms or with a new onset of symptoms in somebody who had been relatively stable, as a first general principle, we can go to the major categories of schizophrenia cause. We actually talked about these in earlier lectures. Dopamine is one pathway whereby a person can get schizophrenia, dopamine being in excessive stimulatory quantities. Glutamate, having decreased signaling at the glutamate receptor, is another pathway to psychosis, and aberrant inflammation is another major pathway. So drugs which knock on the door called dopamine or glutamate or inflammation have a fairly reliable history of producing or exacerbating psychotic symptoms. So some of those, a prototypical example of pro-dopaminergic drugs are the stimulants, amphetamine or methylphenidate. Both drugs tend to get synaptic terminals to release dopamine. And going again to the difference between clinical studies and real-world studies, if you look at the clinical data of moderately ill people with ADHD and no other comorbidities, you'll find, according to that prescribing information, that the risk of psychosis is about 0.2 to 0.5% with therapeutic dosing of stimulants. However, if you go to naturalistic settings like clinics in Canada that treat ADHD, you'll find that the risk of psychosis may be as high as 6%. If you don't believe me, I put the two references so you can see for yourself. That reflects the diversity in natural populations and the difference between natural populations and the very rarefied clinical trial participant. Also, in what gets called ADHD in the naturalistic clinical setting, there's a significant number of individuals that actually are having something akin to prodromal symptoms of bipolar disorder or prodromal symptoms of psychosis. So an example of two things. One, pro-dopaminergic drugs causing schizophrenia or exacerbating psychosis. And two, an example of how naturalistic side effect profiles can differ substantially from the printed information based upon formal clinical studies. Other categories of dopamine drugs are frequently used well, these are some other categories of dopamine drugs. L-Dopa is the prototypical mainstay treatment for Parkinson's disease. That's just a straight up dopamine precursor. And as you load up on Dopa, you will fill the terminals with dopamine, and L-Dopa at certain concentrations can cause psychosis that looks like paranoia you see in schizophrenia. Then, in addition to L-Dopa precursor, we have strategies where we can directly stimulate the D2 receptor. These are some drugs, bromocriptine, which is hardly used anymore. It's been replaced by the synthetic agonist, pramipexole or ropinirole. These are also agents which are, all these drugs, bromocriptine, pramipexole, ropinirole, were developed to treat Parkinson's disease, and they still are used for that purpose. But pramipexole and ropinirole have seen new life as restless legs syndrome treatments, and it's not uncommon to see somebody with restless legs treatment develop high levels of impulsivity or psychosis as a result of that kind of medication. And then we have selegiline is an MAO-B inhibitor. It's very nice as an antidepressant, but it also has a very strong dopamine augmenting capability, and so occasionally you can see psychosis from that. And amantadine is actually a very good medicine to consider to modulate EPS from antipsychotic drugs, but at higher doses you can also risk exacerbating that psychosis. So those are some reviews of the prodopaminergic agents. Glutamate modulators, the classic one, PCP, aka angel dust, produces a really horrible and severe psychotic syndrome. Ketamine is the cousin of that agent, and the news you're going to hear next week probably is the FDA is going to approve a derivative. Well, they're going to approve ketamine again, this time only as the S shape of ketamine. So now we're going to have two ketamines that are approved by the FDA, but the S ketamine is going to get the indication recognized by FDA for the treatment of depression. This will be an interesting turning point in the history of our profession. But don't forget, I predict here and now that you will see the psychotogenic effects of ketamine and S-ketamine when applied across the population at scale. So stay tuned. Dextromethorphan is a cough suppressant. It also augments or interferes with glutamate signaling, and sadly, it's an over-the-counter substance, and there's a certain portion of our young people, well, everybody, but particularly the young people, who found out that they can get hallucinations from it. So it has a moonlighting job as a drug of abuse, but to point out it can cause psychosis. And lamotrigine as well has several actions, but one of them indirectly affects glutamate signaling. And there are very interesting case reports, and I've seen both in my practice as well as in case reports, all sorts of very interesting and bizarre neuropsychiatric side effects from lamotrigine. In my personal experience, I had a guy who was very troubled by intrusive images of beavers with straws in their noses, from which mucus would drip down onto his bald head below. This image was disgusting for him, partly because he had a PhD trained brain that shouldn't be keeping going back to that thing. There's also, if you go to PubMed and put lamotrigine murderous rage, you will find case reports of people on lamotrigine who have turned on murderous impulses, and they go off and back on when lamotrigine is discontinued and restarted. So these are rare side effects to be sure, but they're out there and worthwhile to mention, because we use lamotrigine in psychiatric practice, not infrequently amongst people with schizophrenia. And to be clear, it can be a useful treatment in people with schizophrenia, particularly even more so in people with schizoaffective disorders. So it has, for many people, it can be quite helpful, but for some, it can actually make things worse. And so it's up to us to keep very close tabs on whether things are getting better or worse, and if things are going worse after a new medicine, not to automatically ascribe the worsening to the natural course of illness. It may actually be something of a drug that you just added to try to help somebody. And briefly, inflammation. Steroids are fabulously great at suppressing inflammation, but they're also classically notable for causing what I call manicosis, either manias or psychoses, or combined states of mania and psychosis. So that's there. So those, I've covered the mechanistic categories, and I just want to draw attention to some other things that psychiatrists see routinely. In anti-epileptic space, Keppra, aka levetiracetam is what I call it, that for some reason neurologists are loving this drug for seizure control, and as one who's consulted in state hospitals, I'm hating this drug for productions of violence and worsening of psychoses. So I can fill a page with references from PubMed to describe case reports and case series documenting all sorts of really bad neuropsychiatric sequelae in people that have a psychotic disorder to begin with. So editorially, I see no value to Keppra in a psychiatric patient, because you can use Depakote equally well for the kind of seizures that Keppra is used. So I personally don't like it in psychiatric patients. Topiramate, I'm not nearly as negative on. It has value. It can be used to reduce weight gain associated with second-generation antipsychotic drugs. It can be used to inhibit alcohol craving amongst people with alcohol use disorders. It can be useful as an adjunct in the treatment of schizophrenia. All good things. However, some people who take it actually have psychosis. So another example of it's good for a lot of people, but disastrous for a handful. So it's out there. Another thing I want to point out, I think I mentioned in a couple of lectures, anti-muscarinic drugs are underestimated in general in terms of their ability to do bad things. So the most common agent in psychiatric practice is benztropine. We use it when we've given our patients too high doses of antipsychotic drugs. Usually when you see extrapyramidal side effects, this means that you're blocking more than 80% of dopamine D2 receptors. Data suggests that you can actually achieve antipsychotic benefits at about 60% D2 receptor occupancy by antipsychotic drugs. So when you see EPS, you probably have gone too high. And the ideal solution to that is to begin to reduce the dose to see that side effect goes away. But the faster and easier way is to prescribe benztropine, which works very well for addressing EPS, but also works very well for impairing short-term memory, predisposing people to delirium, and exacerbating mood instability in people with bipolar tendencies, and causing frank psychosis in others. So these things are not obvious to most people, and I mean, let me rephrase that. These side effects of mania provocation or of psychosis worsening are not commonly observed, but they certainly can happen, and I'm just, again, letting you know to interpret worsening as a possibility of being due to this agent rather than some natural feature of the illness. Caffeine, I want to point out, again, for most people, it's a wonderful thing, and I am all for team caffeine myself. But caffeine, I like caffeine, and everybody who loves caffeine loves it because it is an adenosine receptor antagonist. Now, the thing is, when you have less adenosine signal, you actually predispose to aggression, insomnia, anxiety, and psychosis. And so in a psychosis vulnerable brain, or in a brain already with psychosis, in some cases, caffeine can routinely and obviously make it worse. One patient that I know of was doing fabulously well on clozapine, but eventually he realized every time he had coffee, he was either doing worse or back in the hospital. So with repeated on-off, he concluded that it was bad for himself. The mechanism is adenosine blocking. And to help highlight the relevance of adenosine in psychosis treatment, we can use drugs like allopurinol, which is usually seen as a gout medicine, but indirectly allopurinol can augment the signal of adenosine, and allopurinol, presumably by its adenosine augmentation action, actually functions as a effective antipsychotic augmentation drug and also as an effective anti-manic augmentation drug. So caffeine is out there as a potential risk factor. So in the email invitation, I sent you all the paper from which this table appears, the hyperlink there that you'll see on the PDF, which will be emailed to you after this is done, as well as posted on sconsult.org. That hyperlink will take you to the paper itself. Very nice, short paper, concisely written, and Dr. Ambizas has listed lots of medicines. I've talked about many of these things. Fortunately, there's not enough time to talk about the very interesting cardiovascular, antihypertensive drugs and H2 receptor antagonists, but I do encourage you to grab the paper, read it, and just keep in mind that calcium channel blockers or clonidine or propranolol and ACE inhibitors like lisinopril all have associations with psychosis provocation. So it's really great to know that in the back of your mind when you're consulting a case or involved with a case where things aren't responding the way that you would like them to. So to summarize briefly, any drug can cause any side effect in anybody. There are many, many drugs that can provoke or worsen psychosis, and things get extremely unpredictable when you start combining these things. So in the ideal world, a person will be on one medicine for their schizophrenia. In the reality, it may require two, but by the time you get to 3 psychotropic medications, it's probably you, the doctor, or me, the doctor, that's the bigger problem. And so we need to, and again, I've done this myself, so I'm not saying I'm immune to it. I get the pressure, but keep in mind, if I prescribe 3 medicines, I've left the reservation in evidence. And I need to be extremely cautious in interpreting a worsening of symptoms as something that I did rather than the illness just being refractory, I think psychiatrists like to call it. And because things can be unpredictable, when you start adding more medicines, it becomes paramount to know exactly what the treatment is supposed to be doing and tracking that objectively over time and stopping the other treatment if you're not moving your target in a reasonably meaningful way. So those are